Good evening, everyone. Thank you for joining us. So good to see so many of you coming on as attendees. My name is Jennifer Gillick, and I am the Program Director for the Northwest Chapter of the American Parkinson Disease Association, or APDA for short. I'm going to tell you a little bit about us, and then we'll get on to the presentation. So APDA is the largest grassroots network dedicated to fighting Parkinson's disease. Our Northwest chapter is located in, unfortunately, a little bit of a smoky Seattle today, and it works with individuals in the states of Washington, Oregon, Idaho, Montana, and Alaska to provide support, education, and research that will help everyone impacted by Parkinson's disease live life to the fullest. You can visit our website at apdaparkinson.org/northwest to learn about the array of programs and services offered by our organization. The work of APDA is made possible by the support of donors and sponsors. I would like to take a second to recognize the sponsors of this program, Boston Scientific and Kyowa Kirin. Thank you both for valuing these educational programs and for your financial support of APDA. We certainly could not do these types of programs without you. I'd also like to thank those of you who are participating, who donated to our organization when you registered. We truly appreciate your support. If you missed an opportunity to do so and you are in a financial position where you can make a donation, you can do so on our website at apdaparkinson.org/northwest. So today's program is a little bit different than our previous Take Control sessions. Dr. Khemani is going to be presenting 2 different case studies in Parkinson's disease. And through those case studies, he will be discussing the treatment of motor fluctuations, dyskinesias, and prioritizing treatment in advancing Parkinson's disease. This is also a little bit different because due to Dr. Khemani's clinic schedule today, he pre-recorded this presentation, and then he's going to join us at the end of his presentation and answer questions live. You can pose questions to Dr. Khemani at any time during the presentation by typing into the Q&A box. Dr. Khemani Dr. Pravin Khemani is a movement disorders neurologist at Swedish Medical Center in Seattle. He is fellowship trained in both neuromuscular disorders and movement disorders. And he is the author of a number of publications on Parkinson's disease. He is also on the board of directors of APDA Northwest and is our medical director. So thank you again for being here. We hope that you find this program valuable. And now we are pleased to present Conversations and Cases from the Exam Room.
Welcome everyone to Conversations and Cases from the Exam Room, another talk in a series of educational talks on Parkinson's disease from the American Parkinson Disease Association. Today we will be learning about the treatment of Parkinson's disease from 2 real-life examples, patients that were treated in the Movement Disorders Clinic at the Swedish Neuroscience Institute. This format is different from previous formats in that it is a didactic format used commonly in the medical setting. It's a fun way to learn from each other. This is a pre-recorded seminar at the end of which we have a Q&A session, so please stick around. The first case is of Mr. A, a 70-year-old gentleman with Parkinson's disease for 6 years. He is having wearing off and dyskinesias and is referred for an evaluation for higher level care for Parkinson's disease motor fluctuations. What are the next steps in treatment? So what are motor fluctuations? Motor fluctuations are characterized by an off state and on state with dyskinesias. Wearing off or an off state is a period when Parkinson's disease motor symptoms return before the next dose of levodopa. These motor symptoms are typically the cardinal symptoms of Parkinson's disease: tremor, stiffness, slowness, shuffling gait, freezing on occasion. Sometimes non-motor symptoms can occur when the medication is wearing off. These can include dizziness, lightheadedness, brain fog, numbness, or tingling, and other vague symptoms that are difficult to articulate. The on state is when Parkinson's disease symptoms are best controlled with medications. Dyskinesias are abnormal involuntary movements, but they're not tremor. A tremor is more rhythmic, oscillatory, and occurs at rest with Parkinson's disease. Dyskinesias can occur with rest or with action. They typically get worse with stress or anxiety. Dyskinesias can be on or peak dose dyskinesias when the levodopa is at its peak in the brain. Phasic dyskinesias can occur shortly before or shortly after taking levodopa. The on dyskinesias or peak dyskinesias, which occur in the mid-cycle between the two doses of levodopa or two consecutive doses of levodopa, are by far the most common. This schematic illustrates motor fluctuations as a result of Parkinson's disease progression. The first panel illustrates early Parkinson's disease. The second panel represents mid-stage Parkinson's disease, and the third panel illustrates advanced Parkinson's disease. In early Parkinson's disease, when you take Parkinson's disease medications, you have a nice smooth on that can last up to 6 to 8 hours before you take the next dose of levodopa. You may or may not have an off period, which is actually quite small. As the disease progresses and you take levodopa, there is a fairly sharp rise of levodopa in the brain, followed by peak dyskinesias and an on state which is shorter than previous on states and marked by dyskinesias. Levodopa levels fall, giving rise to wearing off or the off state, and an off state which is much longer in duration than previous off state. As the disease progresses, when you take levodopa, there is an even sharper increase in levodopa in the brain, followed by peak dyskinesias, which can be quite severe, an on state with dyskinesias, followed by a wearing off before the next dose of Parkinson's disease medications is taken. And this is typically due to brain dopamine levels, which rise and fall rapidly as a result of Parkinson's disease progression or loss of the buffering capacity of dopamine neurons in the brain. The very first step in treating motor fluctuations is to optimize medications. Carbidopa, levodopa being the most common medication people are taking in the mid and advanced stage of Parkinson's disease. We try to fractionate carbidopa, levodopa, or give carbidopa, levodopa in smaller quantities more frequently. So there isn't a sharp rise and fall of the drug in the brain. This can be effective in minimizing wearing off and dyskinesias. If this is not effective, then we use another medication, at least I use another medication called Rytary, which is a combination of short and long-acting carbidopa, levodopa, which has helped a lot of people with motor fluctuations. Other options are to add amantadine to carbidopa, levodopa for the treatment of dyskinesias. Entacapone and opicapone are two medications that extend the life of carbidopa, levodopa from one dose to the other. Entacapone is an older medication that needs to be taken with every dose of carbidopa, levodopa. Opicapone, which should be coming out shortly, is taken once a day in the morning, and it extends the life of all the doses of carbidopa, levodopa one is taking during the day. I'm excited about this medication, and I am waiting to prescribe it to see if the effects parallel the very positive results that were seen in the clinical trials. Apomorphine sublingual film, or Kinmobi, is not unlike the apomorphine injection or Apokine, except that it is a sublingual film or a small film of medicine, which is fairly unique, particularly in the field of Parkinson's disease. It is placed under the skin for rapid absorption. This is typically used, not unlike the Inbrija levodopa inhaler, to rapidly counter the off state. People turn on in about 30 minutes or so. It has just come out recently, and I have not used it thus far. The Inbrija levodopa inhaler, we have known about it for a while. It's inhaled levodopa, an on-demand medication for off symptoms. You take it as you're turning off, and it acts in the next 30 minutes or so, and can act for at least 60 minutes before the next dose of levodopa is taken. Apokine injection has been around for a very long time. This is injectable apomorphine, and it is used to counter severe OFFs. It acts pretty rapidly, but it is short-lived. Istradefylline and safinamide are two other medications that are added to carbidopa-levodopa to counter OFF symptoms and increase the on period, but without causing dyskinesias. What happens if motor fluctuations persist and after medications have been optimized? Well, then we turn to surgical treatments for Parkinson's disease, and the two commonly employed in clinical settings are deep brain stimulation and duopa, which is a carbidopa-levodopa intestinal gel delivered into the jejunum through a PEG-J tube. Let's quickly look at deep brain stimulation. Deep brain stimulation is the process of surgically implanting an electrode into selected areas of the brain to improve motor symptoms of Parkinson's disease. The motor symptoms that improve most with DBS are motor fluctuations, tremor, stiffness, and slowness. After DBS, regular programming is required, and good outcomes are achieved in about 6 to 12 months after surgery. Here is a simple cartoon of the DBS system. This is the battery pack that is internal beneath the clavicle, connected to the electrode, which is number 2 over here, which is in the brain. And these two pieces of hardware are connected by an implanted wire extension. The entire setup is under the skin. It's not visible. Deep brain stimulation in Parkinson's disease is reserved for patients who have had a very good response to levodopa, but are continuing to have motor fluctuations despite medication optimization, or who have a severe tremor that doesn't respond to even high doses of levodopa. It is important to recognize DBS does not cure Parkinson's disease, but it can significantly improve quality of life. Both sides of the brain, or bilateral DBS, are typically needed to improve slowness of walking. Balance typically does not improve, so if someone's falling, despite best optimization of levodopa, DBS is not going to be helpful in minimizing or treating falls. DBS is excellent for smoothing out the on-off fluctuations. It improves tremors, sniffness, and slowness. It typically does not improve levodopa unresponsive symptoms. Severe tremor is an exception. After DBS, programming is required and diligent frequent follow-ups are required at least every 3 to 6 months for fine-tuning. And DBS does decrease medications, carbidopa, levodopa, but does not entirely eliminate them. So I use this mnemonic DBS in PD to educate my patients who are interested in learning more about deep brain stimulation. Surgical technique is carbidopa-levodopa intestinal gel, or LCIG, also called duopa. This is typically a continuous infusion of levodopa into the jejunum where levodopa is typically absorbed. It consists of a cassette or a container which has the levodopa gel. It is connected to a pump which is connected to the jejunum through a PEG-J tube. This entire system of the tube and the cassette and the pump is external. You can actually carry this over your shoulder. It's not a large device. This is, of course, not drawn to scale. And this cassette needs to be changed every night. So it is basically used to deliver carbidopa, levodopa in small quantities every minute, which is not possible with oral carbidopa, levodopa. So our patient over here opted for deep brain stimulation. The neuromodulation pathway was completed successfully. And the neuromodulation pathway is the selection process for deep brain stimulation, which involves a few steps, neuropsychological testing, education of the patient, etc. It takes about 3 months. And after which, if the patient is a good candidate, deep brain stimulation is done. For this particular patient, bilateral deep brain stimulation surgery was done. His motor fluctuations resolved, Parkinson's disease medication doses were reduced, and quality of life improved significantly. Let's jump into our next case. Mrs. E is an 85-year-old woman with Parkinson's disease for 25 years who recently started hallucinating. She has become quite forgetful for her family. She also has lightheadedness and dizziness when standing, which limits walking and has caused her to almost faint and fall. She has constipation, which is quite bothersome. She's quite dyskinetic. She was on multiple medications for cardiovascular disease, arthritis, bladder problems, allergies, and nausea. So how do we improve Mrs. E's quality of life? What Mrs. E has is advanced Parkinson's disease, and we ought to prioritize treatment because she has a lot of things going on. There are hallucinations, lightheadedness, constipation, dyskinesias, there's cognitive impairment, and polypharmacy, which is taking several medications which may potentially interact with each other. The two symptoms that I'd like to prioritize right away are hallucinations and lightheadedness, because they impair quality of life significantly, can be quite dangerous, but also because they need to be treated with medications first. Treatment of constipations and dyskinesias can make hallucinations and lightheadedness even worse. So it's important to tackle these two issues first, probably simultaneously, to improve these symptoms. As far as hallucinations in Parkinson's disease go, it is important to look at some fundamental things before we give medications for hallucinations. Infections are important to look at, so I do blood tests, urine tests. I want to make sure if the patient has not been ill recently with pneumonias, etc., whether a chest x-ray is needed. I got to coordinate with the primary care doctor in treating hallucinations. Then there are medications that can cause hallucinations, so I'd always like to look at the medication list to see if I can eliminate some of these medications. I order a 12-lead echocardiogram because if I were to start medications for hallucinations down the road, some of these medications can affect the heart rhythm. So I'd like to get a baseline evaluation of the heart to look at things like the QT interval. The common drugs that cause hallucinations include amantadine. This drug is very good for dyskinesias, but when someone's having hallucinations, I try to eliminate this medication. Dopaminergic agonists such as pramipexole, ropinirole, reticotine patch, or Nupro can also precipitate and cause hallucinations, particularly in people over 75 to 80 years of age. So I try to minimize these medications and eliminate them if possible. Apomorphine is another medication that is notorious for causing hallucinations. There are drugs that are used in the treatment of other things that can worsen hallucinations. Bladder drugs are very common. These drugs fall under the class of anticholinergic medications. These are given by primary care doctors, cardiologists, etc., to treat these various symptoms, but unfortunately, they can cause hallucinations. So I'm always on the lookout for these medications that can worsen hallucinations, and I'd like to remove them if possible. Of course, coordinating care with the prescribing physician. So you've done all of this, and then how do you treat hallucinations? You've done your basic due diligence to look for precipitants of hallucinations. You've eliminated them. The next step is to try medications for treatment. This is a list of medications that one needs to stay away from completely. Haloperidol, risperidone, ziprasidone, olanzapine, aripiprazole, lithium, thorazine, flufenazine. These are much older antipsychotics that we do not use in Parkinson's disease because they can make Parkinson's disease significantly worse. There are three standard medications for hallucinations: pimavanserin, quetiapine, and clozapine. Of these three, pimavanserin and quetiapine are fairly mainstream in the treatment of Parkinson's disease-related hallucinations because of the ease of use. Pimavanserin is an FDA-approved medication. It's also called Nuplazid. The problem is it takes about 2 to 4 weeks to become available after you prescribe it. It needs to come from a specialty pharmacy, and insurance may or may not approve the medication. It takes about 2 weeks to show effect. Quetiapine is more commonly used, although it is not FDA approved. It is cheaper, it is more immediately available, and in good doses, which build up over 2 to 4 weeks, it can improve hallucinations. But it's important to recognize that in people with dementia, it has been associated with a higher risk of arrhythmia and death. And hence, it's good to get a 12-lead EKG, inform the patient and the family that, this can occur, it's an issue, but there are no better options or no better immediate options for treating hallucinations. It can worsen lightheadedness. So if someone's already lightheaded, it's important to treat the lightheadedness also as we are treating hallucinations. Jumping into lightheadedness, in Parkinson's disease, like in many other conditions, lightheadedness can occur due to common things like dehydration. High blood pressure medications can cause lightheadedness because that's what they're used for, to lower blood pressure, but low blood pressure can cause lightheadedness. There are several other medications that can cause lightheadedness. Anticholinergics that worsen hallucinations can also worsen lightheadedness. And other medical conditions that we commonly see, such as anemia and diabetes, that can cause lightheadedness. So one's got to do one's due diligence to ensure that these other medical issues are also effectively treated. But the most common cause of lightheadedness in Parkinson's disease, other than dehydration, is a condition called neurogenic orthostatic hypotension, or NOH. To diagnose NOH, one needs to keep a blood pressure and a heart rate diary, and I commonly do this with my patients who have Parkinson's disease who complain of lightheadedness. How do you keep a blood pressure and heart rate diary? You get a good blood pressure cuff, an FDA-approved blood pressure cuff that can be available online, and you measure blood pressure and heart rate laying down first thing in the morning before getting out of bed. Then you stand up by the bed. You can get assistance if you need to for about 3 to 5 minutes and measure the blood pressure and heart rate again. We do this for about 5 consecutive days, and we have 2 sets of reading on each day. You send this particular diary to the doctor or nurse for review. Some people do a sitting blood pressure as well before they're made to stand. I don't think that is necessary. Sometimes you can measure blood pressure right after a meal. Postprandial hypotension that occurs and that can worsen blood pressure or lightheadedness. What is the definition of neurogenic orthostatic hypotension? When standing, what we see in neurogenic orthostatic hypotension is that systolic blood pressure, which is the top number, falls by 20 to 30 points at least, or the diastolic blood pressure, the bottom number, falls by 10 to 15 points, at least in the standing position, compared to the laying down position. And the heart rate does not increase by more than 15 to 20 points when standing up to compensate for the fall in blood pressure. In people without Parkinson's disease, the heart rate does go up because the heart begins to pump blood faster to get it to the brain. But in Parkinson's disease, this compensatory mechanism is gone, and hence the term neurogenic orthostatic hypotension. As a result of NOH, people with Parkinson's disease complain of lightheadedness or fainting or a feeling of being faint most commonly, but it can also lead to imbalance, falls, neck pain, fatigue, not able to think clearly, or brain fog. NOH and Parkinson's disease can lead to blood pressure fluctuations. It can lead to lightheadedness after eating heavy meals, drinking alcohol, eating a heavy carbohydrate meals, getting into hot tubs or taking hot showers because the blood vessels get dilated and blood pressure can fall even more. Additionally, with NOH, you can have supine hypertension, which is a sudden increase in blood pressure when you're laying down. So when we detect NOH, we're also looking for supine hypertension, and we tell people to raise the head of their bed by at least 6 to 9 inches to avoid sudden increases in blood pressure when they're laying down. This is a very important aspect of management of NOH. So how is NOH treated? First, we use non-pharmacological ways of treating NOH. They include consulting the primary care doctor and eliminating all those medications that can worsen NOH if possible. How about the more fundamental things? You have to keep the tank full. At least 3 liters of water per day are necessary. You can salt food liberally, not with salt tablet, but table salts, provided you don't have conditions such as congestive heart failure that can get worse. Raise the head of bed up to avoid supine hypertension, and use compression devices when needed, such as compression stockings, etc. When it is a complex patient who has congestive heart failure, pacemakers, or heart disease, I consult with the cardiologist and let them treat the neurogenic orthostatic hypotension, because it involves treating several conditions at once: neurogenic orthostatic hypotension, cardiovascular disease, etc., and does require a specialist to treat all of these conditions. Once you've stabilized the patient, use non-pharmacological ways of treating neurogenic orthostatic hypotension, and the patient is still dizzy. I use a medication called droxidopa, which is FDA approved. Again, this medication takes about 2 to 3 weeks to become available through a specialty pharmacy, and insurance may or may not approve it. It also takes about 2 to 3 weeks to become effective. So if someone needs immediate treatment of lightheadedness due to a neurogenic orthostatic hypotension and cannot wait for this medication to become approved, I use either fludrocortisone or midodrine. These medications have been around a long time. They're not FDA approved specifically for Parkinson's disease. However, they're immediately available, they are cheap, and insurance does approve these 2 medications. They do have individual side effects. Not unlike droxidopa, fludrocortisone can cause a decrease in potassium in the blood, so potassium needs to be monitored. Midodrine can cause a severe spike in blood pressure, particularly when laying down, so it cannot be given after 5 p.m. Typically, it can cause other side effects that need to be monitored. Let's jump into constipation. This is a major impairment of quality of life in Parkinson's disease. How do we treat constipation? We got to do the fundamental things first. What can constipation do? Unfortunately, it can cause erratic absorption of levodopa and can worsen motor fluctuations, including dyskinesias and wearing off, because levodopa is absorbed in the jejunum. People who are constipated have a low transit time, so the time between swallowing the pill to the absorption of the pill can be significantly increased, and wearing off can be worsened due to hydration. Very important, not unlike treating lightheadedness. So there is an overlapping theme in the treatment of these conditions, as we see, taking in a lot of insoluble fibrous food if possible, eliminating constipating foods such as dairy, or at least minimizing it. I also have the patient consult a nutritionist and an exercise specialist, because we know diet modification and exercise can significantly improve constipation. A regular bowel regimen is important. It is insufficient to have a bowel movement once every 4 days or a week, which I've heard from some patients, which can lead to a lot of problems down the road. And then before we go into prescriptive medications, there's a lot of over-the-counter stuff that is available for treatment of constipation, which is not a problem that is specific to Parkinson's disease, but it's significantly more common. The over-the-counter medications, there are tons, but the ones that are commonly used by patients that are effective include polyethylene glycol or Miralax, which is a stool bulker, Docusate and Senna, which are propellants, which increase peristalsis. Ducolax, again, is a medication that increases peristalsis. Docusate also softens stools. Psyllium increases fiber in the stools. Magnesium citrate is an irritant and a osmotic, and it causes peristalsis. Some of these are also used for colon prep. Lactulose is not commonly used in Parkinson's disease unless the constipation is very severe. It's a medication that's commonly used in people with liver disease who cannot afford to be constipated. What about prescription medications for constipation? Well, there are about 4 that are on the market. Linaclotide, lubiprostone, domperidone, which is a Canadian drug which has been available for a long time, and prucalopride integrity, which I have not used because it's very expensive, relatively new. When it comes to prescribing these medications for constipation, I almost always ask the gastrointestinal specialist for their help to make sure people don't have other conditions that could be causing constipation, such as H. pylori, which is a bacterial infection. So, I always try to partner with my GI specialist or the primary care doctor to look for other causes and to help in the prescription of these medications. Changing gears to dyskinesias, I think we have discussed some of this when we were talking about motor fluctuations. Well, before we even treat dyskinesias with medications, the fundamentals are to treat constipation effectively because it can lead to erratic absorption of levodopa. Again, overlapping themes here. Take Parkinson's disease medications on time with a full glass of water and preferably on an empty stomach at least 30 minutes before the next meal. In addition to these non-pharmacological means of treating dyskinesias, fractionating of Sinemet, which we talked about previously, helps reduce dyskinesias. We talked about Rytary, which can minimize dyskinesias, and amantadine, which is actually used for dyskinesias, but I would avoid it in Mrs. E because it can precipitate hallucinations. How about polypharmacy? Not uncommon. Many medications interacting with each other that can worsen hallucinations and lightheadedness and perhaps constipation as well. What's important to work with the primary care doctor to simplify or reduce pill burden, try to eliminate as many medications as possibly can. We also at Swedish have the GeriComp clinic or the geriatric comprehensive clinic in which the patient can be seen by a geriatrician and a pharmacist. And they use something called the IHI forum approach, which is they talk to the patient, the family, to treat those medical conditions that matter the most. Talk about mentation and mood, which are also important for quality of life. Talk about mobility, which is impaired in Parkinson's disease, and then also talk about medications, of which there can be so many that people are taking for various things to see if they can simplify them. And this particular approach is commonly used by geriatricians to improve the overall quality of life of patients who are taking several medications or who have multiple medical conditions that coexist. How about cognitive impairment? Well, again, the fundamental things are to eliminate offending medications. Anticholinergic medications that are taken for bladder can cause cognitive impairment, and so, if possible, these need to be evaluated. Infections, insufficient vitamins, poor thyroid functioning can cause cognitive impairment. Dehydration and constipation in older individuals can cause cognitive impairment. It's important that we keep people safe when they are cognitively impaired because they can endanger themselves, and also consider medications to treat cognitive impairment if potentially safe. Unfortunately, some of the medications that we use for cognitive impairment and dementia in Parkinson's disease can further lower blood pressure, decrease heart rate, make nausea worse. So before I give these medications, I need to make sure that other medical conditions are well controlled and the patient is stable. For Mrs. E, when we did her evaluation, we found out that she had a urinary tract infection, a bladder infection, which was effectively treated. She found to be dehydrated, which was also treated with fluids. Her constipation overall improved by change of diet and over-the-counter medications. We tried to eliminate as many offending medications as possible. We fractionated the carbidopa, levodopa, smaller doses given more frequently. And the Jerry Comp Clinic saw her and tried to implement successfully the 4M approach, including elimination of some of the offending medications that she was taking. Although her quality of life improved, her hallucinations improved significantly but persisted. Finally, we got pimavanserin for her, which further reduced hallucinations. Her lightheadedness improved significantly with the most commonplace measures, but it persisted and it was bothersome. So we got her an abdominal binder, which worked well for her, and started her on low-dose droxidopa. So overall, it was more of a 360 degrees multidisciplinary approach for the treatment of Parkinson's disease, and a piecemeal approach. We prioritized treatment, and as a result of which the overall quality of life of this patient improved significantly. And I think that concludes my. I thank you very much for your attention. The best slide for last. This program was made available by APDA, and if you like it and if you want to, participate in more educational sessions, please let APDA know. It's a nonprofit organization, and if you're interested in giving a gift, you know how to get a hold of them. Thank you very much. I'm going to hand it over to Jen for the question and answer session. Thank you.
I'm muted. Here we go. Hello, everybody. Thank you, Dr. Khemani. And I believe I'm muted again. There we go. There you are. Hello, sir. Are you muted?
No,
Oh,
I can hear you.
Okay, good. Hi.
Hi.
Thanks for that presentation, and thanks for spending your weekend pre-recording it. And I'm so glad you could come on live. So, so we are going to now open up to questions from the audience. So there's two ways that you can do this, audience members. You can either raise your virtual hand. There is a button that says raise your hand to ask a question, and then I can unmute you and you can ask your question with your voice, or you can type a question into the Q&A box, which is also at the bottom of your screen. Please keep your questions general in nature, and if you're speaking, keep them, well, and typing, keep them short-ish, but we will open it up for question and answer, and we have a couple that were submitted beforehand, so maybe we'll start with one of those. Oh, but you're on the chat there, Dr. Khemani PK, and the first question was, do you recommend DBS for early onset patients? And you answered it, but I'm going to let you answer it verbally in case people don't have their chat open.
DBS is actually approved for early Parkinson's disease. The FDA has approved it, but it is approved for early Parkinson's disease with motor fluctuations. So you do not have to have advanced Parkinson's disease to get DBS. You don't have to wait 10, 12 years. As long as the diagnosis of Parkinson's is secure, the medications are optimized, and people are having motor fluctuations, you can get DBS at any time. Without motor fluctuations, we don't offer DBS because that trial for offering DBS in patients very early before they have motor fluctuations is still ongoing.
Okay. So another question came in. At the end of your talk, you mentioned something called an abdominal binder. What is this?
An abdominal binder is nothing more than a cinch. You can get it through Amazon. People who have had hernia surgeries or other kinds of surgeries in which they need a compact binder around the abdomen to prevent accumulation of fluid after surgery, use an abdominal binder. It's nothing special. The abdominal binder allows fluid or blood that pools around the abdomen, around the lower areas of the torso to be pushed back up to the brain. It's worn when people are upright and walking, and it is helpful in treating the neurogenic orthostatic hypotension symptoms, particularly lightheadedness.
Okay, great. Does it look a little bit like you see checkers in the market wearing like a back brace sort of thing? Is it similar to that in its look?
Yes, it is less complicated than a back brace, and the more sophisticated abdominal binders that are, I think, available in Europe that were studied in Parkinson's disease also have a pressure gauge in which you can increase the tightness of the abdominal binder, the pressure to a certain extent, and there's some parameters that these particular studies identified in terms of how tight should the abdominal binder be. I don't think you have to be that sophisticated. A comfortably tight abdominal binder should be sufficient as an adjunct for treatment of lightheadedness from neurogenic orthostatic hypotension.
Okay, great. Can you say a little bit more about Rytary?
Rytary is a medication which is a mix of regular carbidopa-levodopa to long-acting carbidopa-levodopa, I believe in a 1:4 ratio. The formulation of Rytary allows absorption of the medication through the gut and steady levels of levodopa in the blood. And that pharmacokinetics, or the mechanism of action of Rytary, which allows a relatively steady level of levodopa in the blood, also allows a steady level of levodopa in the brain. So there is not a wide fluctuation of levodopa that going up and down and up and down, and hence there is not a wide fluctuation in the brain. And therefore, you don't have as many motor fluctuations with Rytary as we do with regular levodopa, at least according to the research trial that got Rytary its approval through the FDA.
Okay, great. Another question from the typing. Oh, my computer just took the question away. There we go. Which vitamins do you test levels on?
I test levels on vitamin D if the primary care doctor has not tested. I test by most importantly level B of B12, vitamin B12, which is really important. And there's some suggestion that levodopa could reduce the absorption of vitamin B12, and then people with Parkinson's disease are somewhat more susceptible to having neuropathy more than people who don't have Parkinson's disease. So I always check level of B12, and I tell people to take at least 1 milligram of B12 daily, or a super B complex vitamin daily. A B complex vitamin is one which has B1, B2, B6, B12. I don't recommend overdosing on vitamins, but the B vitamins are very important.
Okay, great, great. One follow-up to the Rytary. Is there a downside to Rytary?
The downside to Rytary is similar to the downside to levodopa, which is it is basically levodopa. So you have to be careful and be cognizant of the potential side effects of levodopa. That is the medical downside. The other downside is because it's a specialty pharmacy medication, it may not be as readily available as levodopa, although the company that manufactures it, Amneal, has made it easy for doctors' offices to order Rytary as long as the people in the doctor's office are educated on how to order it. Our nurses and our MAs have worked really closely with Amneal and truly have, developed a very good workflow on ordering it, filling out the paperwork, basically. It's more paperwork and ensuring that it's done correctly. I think a majority of the patients in our clinic, about 70% of the patients in our clinic, are able to get the medication and afford it, but there are a few patients with not standard insurances with really high deductibles that are not able to afford the medication simply because of the way it's marketed.
Yeah, it's quite expensive, right? It can be if
out
your
of
insurance.
pocket, it is
Yeah.
extremely expensive. I mean, no one purchases medications out of pocket,
Right.
but if the insurance company denies it, yes, it is unaffordable, truly.
Yeah, I've heard that from folks who've called in and said, what can I do? So please, another one, please comment on use of amantadine as an alternative to amantadine. Experienced edema with amantadine, but it did relieve the symptoms.
Before I do that, I have two questions in the chat box.
Oh, okay.
Ed, really quickly, instead of typing them out, one is a question from Liana Marie. She writes, if unable to drink a glass of water with Cinemet meds, what is the next best fluid or delivery method for her? I suppose she's asking about patients. Patient has dementia and advanced Parkinson disease, and the nurses and the nursing home mix her meds with pudding or applesauce. That's perfectly fine, but the pudding cannot be a protein pudding. It cannot be your vanilla milk pudding because protein reduces the absorption of carbidopa levodopa. It's perfectly okay to give carbidopa levodopa crushed with applesauce or a thickened liquid, as long as the liquid does not have protein in it. Any liquid is okay. If someone is choking on thin liquids, then the diet can be modified to give levodopa with thick liquids as long as it does not have protein in it. And then the next question is from Dan Devon. What are the primary signs and definition of lightheadedness? Lightheadedness is exactly that, feeling faint when you stand up, feeling like you're about to pass out. We've all had that symptom. This is transient and fleeting. It can be consistent. This is not the vertigo in which the room is spinning around you. It is a feeling of blackness coming over you, also called syncope. And that is the definition of lightheadedness. Some other signs of lightheadedness is sweating, and heart rate getting significantly elevated, if you're dehydrated, feeling foggy, particularly when your blood pressure drops, not being able to think clearly. Those can also occur in lightheadedness.
Okay, great. Okay, so back to the Q&A box. I'm going to try to monitor both chat and Q&A, but you're seeing the chat one, which is great. So this was a question about amantadine as an alternative to amantadine. This individual experienced edema with amantadine, but it did relieve the symptoms.
I haven't used amantadine. I have used amantadine and memantine.
Okay.
Memantine is a drug that is used for dementia. to the best of my knowledge, it does not have any role in the treatment of Parkinson's disease. Amantadine and its formulations are primarily the medications we have to treat dyskinesias, and indeed, amantadine can cause swelling of the feet. It can cause discoloration of the skin called livedo reticularis. When we see the skin discoloration and swelling of the feet, we have no choice but to either reduce the dose of the medication or completely eliminate it and try to manage dyskinesias another way.
Okay, great. So any other questions from the audience? Any raises of hands? I don't see, oh, I see a hand raise. I see a hand raise. Allowed to talk. Hello, Bob. You have to unmute yourself and then you can talk.
There, I'm unmuted.
There you go. You are, we can hear you.
Excellent. I live alone, okay? I am my caregiver. My question is on hallucinations. How do I know if I'm hallucinating or seeing? In my neighborhood, we have deer that wander through and eat a good portion of my garden. We've got squirrels and raccoons, and earlier in the year there was a porcupine. If I see one, how do I know that I'm not hallucinating, or because there's nobody around to verify? Did you see that deer run through the yard? I just did. Was that there? So I'm kind of out there in Never Land. That's kind of a vague question, but how does someone living alone know if they're having a hallucination, or if the particular smell they're smelling is not something that if there was somebody else around wouldn't be smelling?
Yeah, there's hallucinations occur in two settings in Parkinson's disease. People who do not have cognitive decline or dementia can have hallucinations. So we've had instances of people even in their 40s and 50s having hallucinations without any cognitive decline. And this is a roundabout sort of an answer to the question, but I'm getting to it, if you'll bear with me. And then those hallucinations are due to medications. Once you reduce the medications, the hallucinations go away. And when you don't have cognitive decline, you have insight into your hallucinations more than when you have dementia or cognitive decline. For someone who is living by themselves, who has dementia or cognitive decline, first, they shouldn't be living by themselves. That the cognitive decline itself would endanger someone living by themselves. That's a huge no-no. But if your faculties are intact and you're having hallucinations, or you see things that are there and you're questioning them, but your faculties are intact, this is for visual hallucinations, a couple things can be done to verify it. You have a phone, you call a neighbor, or you call someone who is in the area. Now, if you're living in the middle of nowhere, you can't call anybody to verify if they've seen, the UFO that you've just seen, or the unicorn in your garden, etc. One of the things that you'd have to have is insight into strange shapes, people who are dead, pets who are dead, etc. Those are atypical hallucinations, and you'd know right away. But if you see a porcupine in your yard and a deer running by, those are not bothersome hallucinations. First of all, they don't need to be treated, but there is no way to verify it unless you actually ask someone if they've seen it too. A couple of my patients who live far away have taken pictures with their smartphones of things that they think they have seen. If you actually see that thing on the smartphone screen, you know that that thing was there, because your phone's not going to lie to you if you take a picture. But it is complex when you're living by yourself and you have no one to verify what you're seeing, particularly when you fully believe it is there. That is a typical hallucination. The atypical ones are the ones you can actually identify because they scare you. You actually feel that they're not real. The ones which you don't have insight into, though it'll be impossible to verify because you'd actually act on them. For instance, people with cognitive decline actually believe that their mother is sitting in front of them and she's talking to them, and she may have passed several years ago. So there are also degrees of hallucination and kinds of hallucinations. It all depends on the kinds you're having or truly not having.
Thank you. Okay, another Raitari question, kind of. Have you had success prescribing a combination of immediate release carbidopa-levodopa and continual release carbidopa-levodopa simultaneously as a dose as an alternative to Raitari? This individual tried Raitari, but it took too long to, quote, kick in.
No, I have not had good results with the controlled release 50/200. Now, I have patients who come into my clinic who are doing perfectly well on a combination of the two that I haven't started previously, and I don't mess with that. If you're doing really well on a good combination of controlled release and immediate release, which is not Raitari, that is okay. But the immediate release and the controlled release really cannot be combined to emulate what Raitari does, because the way Raitari is mixed together in a capsule form, there are little beads that get absorbed in a different way. You cannot sort of do that with mixing the immediate release and the controlled release together. You will not be able to see the same benefit.
Okay, great. Do you have certain things, certain programs or charts to chart and analyze off times? Are there ways that you suggest doing that to your patients?
Yeah, there are many ways. One is the caregiver helps, and the patients can themselves document off times. You don't really have to keep a spreadsheet. We don't need off times to the second. So you can do this yourself. Number two, we have something called motor diaries. They are very helpful, and you can pick them up from the clinic. We can send those motor diaries to you via MyChart, and you can actually keep a log of your off time on the motor diaries and then send them to your neurologist or your movement specialist to review. And what we are looking for is patterns. We are looking for predictable offs. Unpredictable offs are are common in Parkinson's disease, but they're difficult to identify. For instance, if you're wearing off at the end of the dose, it's called end of dose motor fluctuations. It is easier to document, yes, more often than not, I'm wearing off 45 minutes before my next dose. That's really helpful information to the physician who can use a medication to extend to bridge the gap, so to speak. We have Kinmobi that came out. We have Inbrija inhaler. We have opicapone. So that pattern becomes really helpful. Wearing off after a heavy meal. That's a great pattern to recognize. Every time you eat meat or you eat steak, you feel that you wear off faster because protein interferes with the absorption of carbidopa. That's a good pattern. So maybe we can increase the dose when you're eating meat or protein, etc. So those are the patterns we're looking for.
And I know that if you are a smartphone user, there are a number of apps out there, including APDA having an app called the Symptom Tracker, which you can download and you can keep track on your smartphone what's happening with your symptoms, and then you can share that with your physician or print off a diary kind of thing. So there are a number of those resources out there, either paper form or on your smartphone. So. Another question from Anonymous. I love Anonymouses. Are vivid dreams on a regular basis a precursor to hallucinations? I seem to go into active dream period at about the same time every night, which I assume is related to wearing off of Cinnamate.
Vivid dreams and hallucinations are two completely different phenomena. Hallucinations are identified as phenomenon or visual phenomenon of things that are not there when you're fully wide awake. Vivid dreams in Parkinson's disease are very common. They can occur with or without medications. And I do not know or believe I know of a connection between vivid dreams and hallucinations. There was another, oh yes, dopamine deficit. Vivid dreams are not necessarily a marker of dopamine deficit. They can occur in the fully treated individual as well.
Okay, great. So that concludes the questions that folks have submitted, and we are almost exactly at the hour mark, which we never do, Dr. Khemani. Maybe this pre-recording is something, I don't know. So I want to thank you for your insight and your time and coming on and answering questions. I want to thank those of you who are here, who have participated. Thank you for being here. I will send a post-event email, and this will also be recorded. The recording will be on YouTube, and the slides will be available to you. We have 2 more Take Control scheduled right now. Our next one is in October, and it is the 5 W's of home care and home health. What's home care versus home health? How do you access it? What is it? So that will be a presentation on the 10th of October. And then on the 13th of November, Dr. Stephen Hamilton, who is a neuro-ophthalmologist, is going to come on and speak about eye issues with Parkinson's disease and what do you do about them. He's done something similar with us a couple of years ago, and it was fantastic. So I really recommend coming on. October will be great too, but I know that Dr. Hamilton does a great presentation. So, and as always, if you have suggestions or feedback for us, please do let us know. We will be doing more of programming like this. So we take suggestions for topics and then we look for an expert to speak on it. So thank you very much. I hope that you all have a wonderful evening. Any parting words, Dr. Khemani?
Just thank you to everybody for spending their afternoon. I want to thank Jen. Jen worked really hard on this format in terms of figuring out how to record, how to present. Usually you don't see the tremendous amount of work that goes behind the scenes. She makes it look really effortless, which is
my gray hair, doesn't that show it?
The hallmark of a professional. But I gotta thank Jen, Jean, and the APDA for always doing such a tremendous job of bringing this all together. So thank you all. Appreciate it.
Thank you, and thank you for your time and energy and effort. So take care, everyone. Until we see you again, have a lovely evening, and we'll see you soon. Bye.
Bye.